Dr. A.K. Gupta. I'm Senior Pediatrician in Delhi Government and formerly I was Additional Project Director at Delhi State AIDS Control Society, where I did this innovative work, which I'm going to present. As all you know, HIV epidemic brought a terrible toll on children and families worldwide, and that despite decline in the new HIV infections and AIDS-related deaths, year on year, the number of children affected by AIDS, that is CABA, and affected families is increasing. By CABA, we mean children who are themselves uninfected, have an HIV positive parent, or have one or both the parents who have died of AIDS. They suffer from all sorts of exploitation by the society, right from stigma and discrimination, and denied all basic fundamental rights. Globally, it is estimated that there may be around 17.5 million AIDS orphans, and most of them, to the tune of 90%, live in sub-Saharan Africa. Regarding Indian scenario, about 2.1 million people living with HIV/AIDS are estimated to be there in India, including 39% women and 7% children. And it is estimated that there are about 70,000 children infected with HIV/AIDS currently. About 42,000 adults that die of AIDS every year, leaving many children as orphans. This suggests dire need to for integration of services for this most marginalized and vulnerable population as a critical pathway for health and development. Way back in 2007, the Ministry of Women and Child Development and National AIDS Control Organization Government of India issued policy framework for children in AIDS, which however could not be implemented by the states for various reasons. Delhi is a low HIV prevalent state of India, and as such, the issue of CABA, that is children affected by AIDS, never received our attention. We thought that this problem is not much in our state. Until in 2010, when NCPCR, that is National Commission of Protection of Child Rights, a legal body of Government of India, entrusted with the task of protection of child rights, conducted a public hearing in many states, including Delhi, and referred 5 children living with HIV/AIDS to Delhi State AIDS Control Society, the agency responsible for implementation of National AIDS Control Program in Delhi, to support for nutrition, health, and education. This moved and motivated us to do a situational analysis of CABA that helped in designing a multi-sectoral response and a scheme for children affected by AIDS as well as PLHI on the basis of household economic strengthening of PLHIV. And this scheme was launched in the year 2012. And before that, we come to situational analysis. In 2010, we identified 1,132 CABA in Delhi. 78% of them were living with positive parent. 18% were single orphan, mostly living with the mothers because they were maternal orphan. Around 18% were double orphan. 3% were double orphan, and they were living with extended family or grandparent or with the elders under the care of elder sibling. And around 0.8% were in the institutional care. At that time, around 11,500 people living with HIV/AIDS were registered in HIV care. Out of them, 766 were children living with HIV/AIDS. Out of those 766 children, 25 were in institutional care. Now, based on the need assessment, a multi-sectoral strategy was planned. Health Department accordingly issued orders for free tests, free blood and blood products, and free treatment of opportunistic infections in Delhi government hospitals on PLHs. And Department of Education issued order to all heads of schools to not deny admission to any child who is HIV positive or who is affected, that is, whose family member is HIV positive. Delhi Legal Service Authority agreed to provide free legal support to PLHIV and CABA. The CABA who were identified, they were provided counseling support, they were motivated for HIV testing, and linked to ICDS scheme for nutritional support, and those who had dropped from school, attempt was made to get them readmitted, and 93% of CABA who dropped from school were readmitted to the schools. Linkage to old age pension scheme for grandparents who were taking care of the CABA, as well as linkage to widow pension scheme of Delhi government to paternal orphans. That was done. And some legal issues were also there, which were addressed to the Delhi Legal Service Authority. While community care was the preferred uh, mode of care, some children were placed in the institutional care in the absence of a caregiver. Way back in 2007-8, a study by ILO, that is International Labour Organization, and Delhi State AIDS Control Society on socio-economic profiling of PLHIV in Delhi suggested that about 40% of PLHIV are below poverty line. Further, seeing the economic hardships faced by CABA through the CABA pilot scheme of NACO, uh, we requested Transport Department and Delhi Metro Rail Corporation to provide free transport to PLHIV and CABA to access the health services and ART, which was denied. We also requested Department of Food and Civil Supplies to provide free ration through BPL ration cards, which was also not accepted. Hence, a need for a special financial assistance to PLHIV and CABA was realized. A state technical working group was constituted, comprising of experts from different departments, NGOs, as well as international NGOs, to work out a financial package suitable to the needs of the different categories of beneficiaries. Four categories of beneficiaries were identified. Category 1, PLHIV, and including children infected with HIV, to be provided financial assistance from Delhi government at the rate of rupees 1,000 per month. Category 2, double orphan children infected with HIV/AIDS, either in care of grandparents or elder siblings or extended family, or in the institutional care, to be provided financial assistance at the rate of rupees 2,050 per month. Condition was for the category 1, ART at least of 1 year duration, and they should be resident of Delhi for last 3 years, and they should have family income was should be less than rupees 1 lakh per annum. For double orphans infected with HIV/AIDS, the condition was that they should be both the parents should have died, and at least one due to HIV/AIDS. The third category was destitute children infected with HIV/AIDS in institutional care in Delhi, to be provided financial assistance at the rate of rupees 2,050, and condition was that they should be initiated on ART by the institution. On attaining the age of 18 years, both double orphan children infected with HIV/AIDS and destitute children infected with HIV/AIDS in institutional care, their scheme was switched over to category 1. That is, the benefit which they were getting was earlier was 2,050 per month. Now they will get rupees 1,000 per month because they have become major. The fourth category was double orphan children affected by HIV/AIDS. Means the children were HIV, but probably they were HIV negative. They were in either in institutional care, both of the parents of these children had died, and at least one due to HIV/AIDS. And the amount of financial assistance proposed was rupees 1,750 per month. Since none of the international NGOs as well as the local NGOs came forward for funding for the CABA and PLHIV, we identified 4,500 PLHIV who were below poverty line. We identified 14 double orphan children infected with HIV/AIDS. We identified 25 destitute children in institutional care and 21 children affected by AIDS right in the beginning of the analysis. So, therefore, since there was no funding from any other source, we thought that we should put up a proposal to Delhi government. And fortunately, Delhi government accepted our proposal, and the scheme was launched on 12th April 2012 as a financial assistance scheme for PLHIV and children affected by AIDS. This was the first government-sponsored scheme at that time in India, from any state government. It was based on the principle of household economic strengthening of PLHIV. That means there was no restriction on the number of beneficiaries in a family, and for providing incentive for broader behavior change. That is to improve the ART adherence, improve the school attendance, nutrition, as well as the health seeking behavior of the beneficiaries. To launch the scheme, certain safeguards and robust monitoring was put in place. ART centers, that is anti-retroviral treatment centers, staff was instructed to identify the beneficiaries and collect their documents, screen them for eligibility, and forward them to Delhi State AIDS Control Society for evaluation by the State Screening Committee, consisting of experts from different departments. On recommendation of the State Screening Committee, the beneficiary was enrolled category-wise into the scheme, and the financial assistance was to be released directly into the bank accounts of the beneficiaries. Since 2016, Delhi State AIDS Control Society is using public financial system of Government of India, which is a very foolproof system, as it is based on Aadhaar ID of the beneficiaries, and there are direct parent transfers, so there is greater accountability and transparency. On completion of 1 year of the scheme, we did the evaluation of the scheme so that to find out the shortcomings as well as to do the improvement in the scheme if required at any step. And that was done by doing a SWOT analysis. The strengths of the scheme was because the scheme was handled by the staff involved in the National Control Program, so chances of stigma and discrimination was least. Also, corruption was least likely because the beneficiaries were registered at the ART center where they were getting the treatment. Except the double orphan children affected by AIDS who were enrolled through the NGOs, and those who were at the institution who were positive, they were also enrolled through the ART centers. And moreover, in this scheme, the main strength was that we were promoting community-based care, and therefore there was no sibling separation. There were certain shortcomings we identified. First was the double orphan children. They were enrolled into the scheme only after getting the HIV report of one of the parents as positive. This was very difficult. Similarly, single orphans who were HIV positive, they were granted same benefit as given to those children who were positive and living with the family. So this was a drawback in the scheme, that they should be given more benefit, financial benefit, compared to those who are living with the parent, because most of them are paternal orphan and mother was not working also. And moreover, children affected by AIDS who were single orphan, they were not at all included in the scheme. This was another drawback. And one more point was that children who were on ART, there was a condition that child should be on ART for 1 year before inclusion into the scheme. Whereas, since there is high mortality in children, the ART has to be started immediately. Therefore, the benefits should start immediately rather than after 1 year of ART. So this was another drawback of the scheme, that we should start financial assistance to children who are HIV positive immediately and at ART of any duration. There was an opportunity of the scheme that there was announced ART registration, there was announced adherence to treatment, better attendance in the schools, better nutrition, and better health seeking behavior. One threat we initially thought was that because this was the first scheme of any state government in India, so there was a potential danger that people from other states can migrate to Delhi to get the dual benefit of the ART as well as the financial assistance from government. So therefore, we kept the criteria of 3 years residence in Delhi and 1 year ART in Delhi, so that this can be prevented, and other state governments should come forward and also do something for their population, vulnerable population. Now, we also presented the achievements of this scheme at the end of 1 year at a SARC summit for children affected by AIDS, which was organized by UNICEF in Kathmandu, Nepal in 2013, where it was adjudged as one of the best practices of a SARC nation. Now, seeing the difficulties faced by the scheme was going on, and There was a grievance mechanism also in place, so we were getting grievances from people that they are finding difficulty in getting live certificates from ART centers because that was required every 3 months. So that was removed, and only after initial registration for the scheme, the income proof was required. But later on, for continuation of the scheme, only undertaking of the beneficiary was enough. For in case of double orphans, the condition that the HIV status of the parent is the report is required, that condition was removed, and because children most of the time get infection perinatally, so so if the child is a double orphan and HIV positive, that is good enough to transfer in the benefit. Moreover, there was a rise in the cost inflation index. So government decided in 2018 to enhance the amount of assistance, and in fact doubled the amount of financial assistance, and it linked it to cost inflation index, capping up to 5% per annum. Government also decided to provide transport allowance to each beneficiary who was visiting ART center at the rate of rupees 120 per visit to the center, to a maximum of 2 visits per month and maximum 12 visits in a year. Delhi model has entered into 11th year with a steady increase in number of beneficiaries from 1,110 enrolled during 2012 and 13. Now about 5,525 clients have been served in the first 10 years, and it has resulted in 100% ART adherence in the beneficiaries. That is the hallmark of the scheme. And also, eventually, it has reduced the mortality in the beneficiaries to only 5%, whereas we see generally it is around 10% in the PLHs who are registered at the ART center and getting ART. The annual expenditure on the scheme during the financial year 2021-22 was USD 1.545 million, which was around 0.12% of the outlay of the Health and Family Welfare Department of Delhi government. Applying Delhi's expenditure nationally would cost 1.6% of current total outlay of the India's Ministry of Health and Family Welfare. Hence, the scheme is implementable on a larger scale, but requires commitment to take it forward. Though the number of beneficiaries of the scheme appears low, appears small, but the efforts showcase the innovative idea and the steps that may be followed in planning package of interventions for CABA and OVC, that is orphan vulnerable children infected or affected by HIV/AIDS, and that the state government can facilitate can by doing financial assistance for such an intervention, and it showcased that state government can financially support such an intervention successfully on long-term basis at a time when international funding is becoming more and more difficult.